The image in the New England Journal is this one, and this is a snap diagnosis. We look inside this young person's mouth, and we can see inside his nasal cavity, and there are pigmented lesions here. This is not Addison's disease. He's had these since birth, and in the middle picture, we can understand why he has acute abdominal pain, because in this CT image, this is called an intussusception, where a piece of small bowel has entered probably the large bowel, resulting in a bowel obstruction. And these invaginations or intussusceptions usually have leaders, and in this case, the leader is a large polyp, which then results in abdominal obstruction, a surgical emergency. We are offered Peutz syndrome, Henoch Schönlein Purpura, Syphilis, Melanoacanthoma, and Crohn's disease. I've never seen this with Crohn's disease. Melanoacanthoma is something else, and syphilis causes practically everything, but I've never heard of its causing intussusception. So we're left with Peutz syndrome or Henoch Schönlein Purpura. And this is Peutz syndrome, as the correct answer shows. And this is a genetic disease, autosomal dominant. The lesions inside this person's mouth and also the polyps that occur in the gastrointestinal tract are benign tumors, hamartomas these are called. But nevertheless, this condition is also associated with malignancy because Peutz syndrome, as we now know, is caused by mutations in the serine threonine kinase called STIC11. And it's an autosomal dominant condition. Here's another example here, and we can see all these pigmented lesions inside this young person's mouth. And in the upper picture here, this is an air contrast barium enema. These aren't done anymore, but this is also an example of intussusception. And obviously the film has been made upright because, as we can see from the air fluid levels, this film was actually taken horizontally. Now this condition is associated with malignancies and has to be separated from other diseases that are also associated with skin spots or spots inside mucous membranes, such as the McCune-Albright syndrome, which looks entirely different, and the Cronkite-Canada syndrome. You don't have to worry about these things. I'm not aware of any specific treatment for STIX11 mutations other than to be aware that these people have a higher risk of malignancy. And the appearance of intussusception is not rare, and you have to be aware of it so that these people are treated properly. An example of melanoacanthomas are seborrheic lesions, which all old people get to some degree. If you have this many, it may also indicate an underlying malignancy. But melanoacanthomas don't cause intussusception. On the other hand, intussusception is seen with Henoch Schönlein Purpura. Schönlein was a physician at the Charité in the 18th century, and Henoch was a dermatologist that described these lesions. And as we can see here, this is a purpuric rash, and details are in the upper picture here. These can be dramatic. And this is, in essence, an IgA vasculitis associated with the IgA deposits that can also occur in the kidney, as in IgA nephropathy. That may accompany Henoch Schönlein Purpura, but not necessarily. And the etiology and pathogenesis of this condition is still not entirely clear, but Henoch Schönlein Purpura can also result in bleeding in the wall of the small intestine that can also result in leaders that cause intussusception, as shown here. Now, the first topic in the New England Journal is Parkinson's disease. also called previously paralysis agitans. And this is a disease that occurs in older men and women. It can have a genetic basis, but 70% of people with Parkinson's disease have an idiopathic form. This is a neurodegenerative problem that results in rigidity. So if you move these people's extremities, you can feel a cogwheel rigidity as you try to extend and flex arms, for instance. It's also associated with a tremor when the people, they have to be awake for this, but when the people are at rest, they can develop tremor, which when they move, the tremor goes away during movement and then starts up again when they're again at rest. They also have a whole variety of postural instabilities and gait disturbances. This is a classic disease, and if you're a physician, you're going to encounter this, and so you should read about it. Now, Parkinson's disease is caused by loss of dopaminergic neurons in the brain, and is a part of the brain called the substantia nigra. And we can increase dopamine levels in the brain by administering L-Dopa. And this treatment has been around since the 1970s and is still the primary treatment for Parkinson's disease. Now, what we try to do when we give this medication, instead of having either immobility or rigor or tremor, we try to get some sort of a compromise between these various states of affairs by increasing the amount of dopamine that's available for these dopaminergic neurons in the substantia nigra. And the drugs that we use for this are L-Dopa. Alone, it doesn't work very well because it's catabolized very quickly within the circulation. So in order to get around this problem, L-Dopa is given with carbidopa, which has a similar structure, which diminishes the catabolism of L-Dopa so that it can enter the central nervous system where it's metabolized by tyrosine hydroxylase to produce dopamine. So that's how this preparation works. And this is still the best, not the only, but the accepted treatment for Parkinson's disease because it improves rigidity and decreases tremor. It's a difficult treatment. There's been the impression by neurologists that starting this treatment early has a disease-modifying effect and delays the degenerative course of Parkinson's disease. And that hypothesis was studied in this investigation that tried to determine whether or not Levodopa-carbidopa has a disease-modifying effect in addition to ameliorating the symptoms from Parkinson's disease. So patients with Parkinson's disease, new onset Parkinson's disease that had not been treated, were randomized to two groups. One group started L-Dopa early, and this group was treated with 40 weeks of L-Dopa, and the second group started L-Dopa late, and they were observed for 40 weeks before L-Dopa-carbidopa were administered. Then at the end of 80 weeks, the groups were compared to see if the group that had started L-Dopa earlier would have a better outcome if their Parkinson's disease was better, and that was determined by two accepted Parkinson's disease rating scales, with the idea that if L-Dopa-carbidopa indeed has a disease-modifying effect, the group that started early would have a better outcome than the group that started late. So these are the outcomes. And as what we can see here, you can't see the p-values. The primary outcome was the change from baseline to 80 weeks in the UPDRS score, which is based on 30 different parameters that I'm not going to show you here. And then there were also secondary outcomes and there was no significant effect. So if we look at this, here's the early group. Their scores actually decrease, which means they got better to week 40, and the delayed group stayed where they were. And then these groups come together, and there's absolutely no difference between the groups after randomization at week 80 in this score or in this second accepted score for evaluating patients with Parkinson's disease. So at 80 weeks, the percentage of patients with motor complications, dyskinesias, fluctuations in motor response, and a whole bunch of other parameters was not significantly different between the two groups. The idea that this therapy might have a disease-modifying effect came from the L-DOPA study that was done years ago, where the treatments were stopped, and it looked like the patients that had started L-DOPA for a longer period of time did better than the group that had not been treated in the same fashion. But the results of this more precise study, in my view, does not support the idea that treating Parkinson's disease earlier has a disease-modifying effect. So I guess we should administer the treatment in terms of ameliorating symptoms, but we shouldn't give the patients the idea that necessarily this treatment alters their outcome, which is unfavorable. I had never heard of this next topic in the New England Journal. This is called endometrial scratching. I'm aware of endometrial curettage, which is done for a number of medical reasons, including therapeutic abortion, but that involves removal of the endometrium with a curette. And this device is actually sort of a biopsy pipette. And the idea here is that by stimulating the endometrium, some sort of benefits could accrue. You can look in Google for all of the conditions that this treatment has been administered for. The rumor has it that endometrial scratching would have a favorable effect on in vitro fertilization. Endometrial scratching can also is fairly remunerative because you can bill for it. So this hypothesis was tested in these women undergoing in vitro fertilization, with the idea that endometrial scratching would result in a better outcome than just leaving the endometrium alone. So fairly complicated events here that you can follow if you wish, how the 3,627 women were evaluated for this study, and then if they were willing to participate, and which cycle were they in, and what sort of endometrial or what sort of in vitro fertilization strategy was done, and what sort of hormonal treatments they had. This is fairly complicated in order to test a hypothesis like this. So lastly, there were 650 women in the scratched group and about a similar number of women in the unscratched group. So again, this procedure involves obtaining, you can obtain an endometrial, this is actually a biopsy pipette that's used for this technique of scratching. So here are the patients, 690 in the scratched group compared to 674 in the control group. And we can look at the causes of their subfertility and the type of subfertility that they had, and previous attempts at embryo transfer, and whether or not they smoked, and these kinds of things. Body mass index, all of these variables were similar in the two groups. And then we also have to consider their in vitro fertilization cycle, and whether or not the contraceptive tablets were used, and insemination methods, and their status at time of embryo transfer, and all of these variables need to be controlled, and they were similar in both groups. And then we have to consider about whether or not the this was whether or not this is a fresh embryo transfer or a frozen embryo transfer, and the types of embryo transfers also have to be similar in both groups, and indeed that was the case, and there were no significant differences. And then if we look at outcomes, you can look at these adjusted odd ratio scores here in the red box. There's absolutely no difference in outcomes. So endometrial scratching doesn't help. And so this procedure should probably be abandoned. Now, the next topic is so complicated that I had to use about 5 slides so that I could understand it, and hopefully I can introduce it to you. The topic here is thrombotic microangiopathy. And this is an inflammatory thrombotic condition of small blood vessels. And it involves red cells, it involves platelets, it involves clotting factors, it involves endothelial cells, and it involves von Willebrand's factor, which is a protein made by endothelial cells that serves the purpose of tethering platelets. And the idea here is to ameliorate small injuries so that platelet plugs are formed so that bleeding sites don't occur. This is a fairly complicated state of affairs, and when this relationship between von Willebrand's factor and platelets and erythrocytes and a whole variety of other things that we're going to discuss, if that doesn't work properly, then thrombotic microangiopathy can occur. Now, if thrombotic microangiopathy occurs primarily in the central nervous system, we call this thrombotic thrombocytopenic purpura, and that's abbreviated TTP. This condition was described by a clinician, Eli Moskowitz, in 1924. So TTP is thrombotic microangiopathy, primarily involving the brain and the central nervous system, while renal function is normal. Now, if thrombotic microangiopathy involves the kidney, this condition is called the hemolytic uremic syndrome. The pathology looks about the same, although the renal involvement is in the foreground and central nervous system involvement is less pronounced. Now, the hemolytic uremic syndrome can be provoked by Jegher toxin, which is released by a variety of bacteria, including E. coli O157. Now, this entire relationship between the formation of these thrombi, von Willebrand's factor, platelets, and erythrocytes also involves the complement system. Makes this even more complicated because a variety of genetic alterations in complement can induce thrombotic microangiopathy. So again, the endothelial cells make von Willebrand's factor that binds the platelets, involves in erythrocytes, and this relationship between von Willebrand's factor and the platelets is regulated very tightly because von Willebrand's factor and one platelet results in a monomer, but multimers can occur, and if they can occur in an uncontrolled fashion, thrombotic microangiopathy can result. So this process is also influenced by an enzyme called ADAMTS13 that can cleave von Willebrand's multimers to balance the relationship between the tendency to form platelet microthrombi or platelet plugs or the bleeding tendency that we associate with von Willebrand syndrome. And so basically, here's an example, endothelial cells making von Willebrand's factor, shear stress is involved here, and if ADAMTS13 doesn't work properly, then multimers are formed, and then thrombotic microangiopathy can result. Now, shear stress is important, and you should be aware of the fact that if people that have aortic stenosis, for instance, tight calcific aortic stenosis, they develop, in essence, a clinical von Willebrand's deficiency that can result in a tendency to bleed, which their surgeons might like to know about, because then the relationship between ADAMTS13 and the cleavage of von Willebrand's multimers is altered. Now, what we do for thrombotic microangiopathy is the idea is to remove the multimers from the plasma and to replace the multimers and the old plasma with new plasma containing perhaps ADAMTS13, because deficiencies in ADAMTS13 or making antibodies against ADAMTS13 could also result in thrombotic microangiopathy. And so we use plasmapheresis to treat thrombotic microangiopathy, whether it involves primarily the central nervous system in TTP, or if it involves the kidneys in HUS. Now, complement is involved here, and we have an antibody against complement activation, and this antibody is called eculizumab, and it's also used particularly to treat hemolytic uremic syndrome. And there's a lot of debate about when this antibody treatment should be applied. It should certainly be applied in patients that have genetic alterations in complement leading to thrombotic microangiopathy. Now, eculizumab, to my knowledge, costs 30,000 euros per treatment, and the healthcare systems are not delighted in paying for this treatment. Now, in the study that I'm going to show you, we're talking about a different antibody, and this antibody is called caplacizumab. And caplacizumab binds to von Willebrand's factor in such a fashion that multimers, resulting in strings of multimers, their formation is inhibited by the presence of this antibody. That's the background story. Now we can look at the study. So caplacizumab treatment was applied here in patients with acquired thrombotic thrombocytopenic purpura. Acquired means that it's not a genetic form. And exactly how it comes to be, Dr. Moskowitz didn't know either, and so to this day we don't know exactly. But at any rate, finding patients with thrombotic thrombocytopenic purpura is not that trivial. So there are 72 patients in the antibody group and about a similar number in the 73 patients in the placebo group. Now these patients don't have renal failure, so their serum creatinines are normal. This is not HUS, this is TTP. But they have thrombocytopenic purpura, they have thrombocytopenia, and most, but not all of these people in the study had a deficiency of ADAMTS13, so that the cleavage enzyme to get rid of multimers, the endogenous cleavage, didn't occur. Whether this is due to antibodies against ADAMTS13 or some other cause isn't entirely clear. They didn't all have ADAMTS13 deficiency, but most did. And they've been subjected to a number of different treatments, mycophenolate mofetil and hydrochloroquine and even bortezomib, cyclophosphamide, cyclosporin, various things. And of course, they got lots of plasmapheresis. So this first graph shows the reversal of the platelets to normal. Now that also happens in the placebo group because they're continually being treated with plasmapheresis to give them fresh plasma with ADAMTS13 and to remove the multimers. But it did improve a little faster in the caplacizumab group than in the placebo group, and that difference, although not profound, is evidenced here. Now, if we look at the other endpoints, in other words, not only improvement of the platelet count, but the secondary endpoints, including a composite of TTP-related death, recurrence, or major events, that was significantly less in the antibody-treated group. The recurrence of TTP was also less, and the number of days that plasma exchange had to be performed for clinical reasons was also reduced, and the total volume of plasma that these patients were given was also reduced. The number of days of hospitalization were less. And so it looks like this antibody treatment probably helps people with TTP. Whether or not this has any relevance to HUS, I don't know, but I would think that it might. And if we look at the antibody group, here are the circles, and the placebo group are the triangles, and ADAMS 13 activity looks like it's higher in 2 distributions, and the number of relapses seems to be less. And so it seems like this treatment, you can look at a whole bunch of different subgroups. Not everybody is helped, but I don't know why nosebleeds should be more common in people that got the antibody. That's not the point here, but you can look at these individual characteristics. So that I think that we can conclude that this antibody treatment offers something else for people with thrombotic microangiopathy. So it's important to know about these. Von Willebrand's factor, incidentally, is the most common genetic cause of hemorrhage, not hemophilia. And it's important to know how von Willebrand's factor works and the interrelationship between von Willebrand's factor and platelets and the formation of microthrombi, and you need to know about ADAMS 13. The next study involves dapagliflozin and cardiovascular outcomes in patients with type 2 diabetes. Now, dapagliflozin inhibits the sodium glucose cotransporter 2, SGCT2, and we've looked at similar studies with similar agents that also do the same thing. And the idea here, this looks like a sensible treatment for type 2 diabetes, and the investigators here were interested in hard outcomes instead of whether or not blood sugar is better and whether or not the people gain weight, and they lose weight, as a matter of fact. So the hard outcomes here were major adverse cardiovascular events, myocardial infarction, stroke, and this sort of thing, but also the course of diabetic renal disease, and whether or not these patients got heart failure and had to go to the hospital. And what we see here is cardiovascular death or hospitalization for heart failure. Here's the real world down here at the bottom. These things hardly occurred. But indeed, if we expand the ordinate here, dapagliflozin looked better than placebo. And exactly why inhibiting this transporter would have relevance to heart failure, to me, is not entirely clear, but it's a positive outcome and we'll take it. In terms of heart attack or stroke, no great difference, but at this stage in the game, over this period of time, it might be unreasonable to expect an effect here. What's perhaps more important is the renal outcome, and it's also better with dapagliflozin compared to placebo, whereas death from any cause in this relatively short-term study was no different. And so if we look at this, dapagliflozin better, non-cardiovascular causes, and it looks like hospitalization for heart failure and a renal outcome. And these are very welcome effects. They've been described for other drugs in this class, but again, inhibiting this glucose, sodium glucose cotransporter in the kidney is a very welcome strategy for patients that have type 2 diabetes. And in terms of safety, this treatment appears to be safe. I'd make you aware of the fact that diabetic ketoacidosis can occur with this treatment for a number of reasons that we needn't discuss here, but it's not common. And this is the percentual difference, 0.3% here compared to 0.1%. Genital infections, so the people have to use soap and water, bladder infections and this sort of thing, but otherwise this treatment is fairly well tolerated. So dapagliflozin did not reduce major adverse cardiac events, but it did lower the death or hospitalization from heart failure, and it had a positive effect on renal outcomes. The next topic in the New England Journal are Siam Yz Twins, and they're named after these 2 twins called Chang and Eng Bunker. And these twins lived in the 19th century to a pretty old age. And this is a problem in monozygotic twins, that in essence, their blastocysts by age 13 days in utero should form two independent units, two embryos, but this separation doesn't properly occur. And these twins are usually joined at the chest, hips, abdomen, and also at the head. And if they're joined at the head, this is called craniopagos. And what we see here is two young ladies that have craniopagos. These are monozygotic twins that were born, as we see here. Here they are. I think they're about 3 months of age in this picture, kept alive in the hospital. And we now have imaging techniques that can help surgeons decide what they should do, if anything. And if we look at the imaging, the desirable thing here is that they have two separate brains, so their brains are not fused. But the vascular system, particularly the venous drainage system, is a problem here. So the surgeons are confronted with these two infants here, and what should we do? Well, the imaging and the computer modeling has made such progress here that now the surgeons can take their time, develop a strategy. How are we going to deal with this? And the first thing that the surgeons decided to do is, let's see if we can separate these heads a little bit before we make it. So we'll do the craniectomy part here so that the skulls are separated, but we won't touch the vasculature or the drainage system until the twins are a little older. So what they did is, these are mechanical separators here. This is a distraction osteogenesis technique, if we look at this. And they are slowly moving these two twins apart, causes some pressure sores and ulcers and this sort of, that's not desirable. But what we can see here is that the twins have been separated enough so that they now are about 180 degrees apart instead of being angulated. And when they reach that level, then the surgeons can look at the bridging veins, and then they have to decide on a strategy, because there's a common sagittal sinus here, and this is the primary problem, is to provide venous drainage for these twins. So one twin ends up with more sagittal sinus than the other one. It's the luck of the draw. Siblings, there's always one favored sibling in every family. So this operation took 21 hours, and teams worked on this to very carefully pull this business apart and to separate these two young ladies. And as you can see here in the bottom right, they're already sucking their fingers and picking their noses, so it looks like a success for this operation. So 11 months after separation and at 21 months of age, the development of the twins is not entirely the same, but they both seem to have a crack at having a relatively normal life after this operation, although they each spent a long, over a year in the hospital before they were able to go home. The review in the New England Journal is also extremely difficult. It has to do with pain treatment in intensive care units. I spent a lot of time with this topic. And pain is measured according to the dolorimeter scale. It's almost as if the Americans had cloned the dolor gene. And we can sort of, you ask the people how they're feeling. And how many of them ever tell you that they feel like this? Or even this? They always say they feel like that. And nowadays, the treatment of pain has medical legal ramifications, because patients can complain to their attorneys if they don't think that their pain treatment was adequate. And what do we do in intensive care units where people, I suppose, have a lot of pain and have to be sedated and perhaps even paralyzed if they're on a ventilator? And then how much pain do they have? And if they're not conscious, can they point at the little smiley face here to tell us how they're doing? This is a very difficult topic, because most of these patients get some sort of opioid, because other analgesic agents are largely worthless anyway. And how does this impact on NMDA receptors, and how does it do with GABAergic transmission? And can this in and of itself cause inflammation? And this is a very important topic in this very complicated review that reviews afferent pathways and efferent pathways and a whole host of protein mediators, calcitonin gene-related peptide and NMDA receptors and things of this nature. So if you deal with treatment of patients in intensive care units, you're going to have to know about this, and you're going to also have to know about the pharmacokinetic and pharmacodynamics of the compounds, and the induction of cytochrome P450, and how that influences dose, and how the metabolites influence further metabolism, and whether or not the metabolites are active, and whether or not all of this therapy is effective, and how much opioid should be administered in patients that can't answer your questions, and whether or not we promote harm through damage-associated molecular pathogens and influencing NF-kappa B signaling. And the complexity here is amazing, and the answers, how these patients should be treated, is not clear, but this is a difficult topic that should confront physicians that work in intensive care units. At least, even in my time, we allowed the patients a chance to wake up every day to see if they still needed to be on a ventilator. And then the strategy of opioid rotation, and which mu receptors you're dealing with, and multimodal analgesia, and then what are our options? It says here acetaminophen or paracetamol in Europe is a weak analgesic. It may not be an analgesic at all. At least a number of randomized trials looking at acetaminophen against placebo haven't shown that acetaminophen is much better than placebo. But perhaps in people that are in coma, they react different to placebo than other people. Now, the patient in the New England Journal is also a problem. This is a 70-year-old woman that comes in several times with fever, headache, and shows signs of encephalopathy. And the physicians taking care of her consider a number of different options, and because she lives in Massachusetts, Borrelia antibodies are analyzed here, and they weren't found, and didn't know what was wrong with her, but quite appropriately, she had a lumbar puncture done. And as luck would have it, the first lumbar puncture at the outside hospital showed 579 red cells per cubic milliliter. That's not very helpful, because the difficulty here is this caused by disease, or is this caused by a traumatic tap? And herpes simplex encephalitis is also characterized by having some erythrocytes in your cerebrospinal fluid. And if we look at the other cell types, there's some neutrophils here, lymphocytes, 76 lymphocytes, that's a little high. Protein should be under 40 grams per deciliter, and it's 61. Glucose levels are okay. Gram stain was done, not helpful. And then sent home, antibiotics are started. She refused certain treatments for probably good reason. She was started on vancomycin, piperacillin, and with tazobactam, and she declined admission to the hospital, so she was sent home on doxycycline. Didn't get better. Had a couple of more LPs done. This time less erythrocytes, making the diagnosis of herpes simplex encephalitis less likely, but again, increase in lymphocyte count and protein count is slightly above normal. So what does she have? This magnetic resonance imaging study here is done, and it shows involvement of the cerebellum. Had the temporal lobes been involved here, we would think more about herpes simplex encephalitis. So the question is, what is going on here? And the discussant mentions non-infectious causes of encephalopathy. One possibility is an autoantibody disease, where people make antibodies against NMDA receptors. This is called anti-NMDA receptor encephalitis. This is generally a disease of younger persons. Bacterial infections are probably ruled out by the various cultures and 3 LPs in a row. The same for fungal. Protozoa, we have no history of swimming in any ponds, and so Naegleria fowleri is less likely. And then there are viruses. And could this be a viral encephalopathy? And herpes simplex has been mentioned. And could this be an arthropod-borne virus? And these occur in New England, and they are transmitted by various vectors, and this has to be considered. And there are antibody tests for this, and West Nile virus was looked at, and a bunch of other St. Louis equine encephalitis virus was looked at, and it turns out that she has Powassan virus. I thought this might be a town in North Korea, but actually Powassan is in Ontario, Canada, where this condition was first described from a young boy who eventually died from it. And apparently this virus involves the cerebellum, which fits pretty well with this MRI picture. No specific treatment for this condition, have to be patient. It started to go away, and she's now able to walk and is transferred to a nursing home. So here's a question out of the New England Journal. You're supposed to decide what this patient here has. It's a renal disease. And this person has a diffuse erythematous maculopapular rash and acute kidney injury. That means her creatinine doubled or something of this nature. And we learned that she was given amoxicillin 2 weeks earlier for streptococcal pharyngitis. So could this be post-streptococcal GN? I guess it might be. But her laboratory testing shows normal complement levels, and her urinalysis shows white cells and not very many red cells, and there's no comment here about red cell casts, and so we're asked what she has. Well, with this palette of things here, I guess she probably ought to have acute interstitial nephritis related to her antibiotic treatment. Now, developing acute interstitial nephritis from amoxicillin is not common, but it has been described. Now, if we look at the Lancet, we can see that the first paper in the Lancet involves a natural experiment. And what was done here in Scotland is they lowered the alcohol levels that you're allowed to drive with from 0.08 grams per deciliter to 0.05 grams per deciliter in the hope that automobile accidents would be decreased. Well, the strategy here presupposes that people that have alcohol levels between 0.05 and 0.08 cause accidents, which I suppose is possible, but I would think that most accidents that are involved with alcohol involve levels that are 10 times higher than this. But at any rate, that's what was tested here: Scotland, England, and Wales. Now, whether or not the UK police stopped more drivers to test them isn't entirely clear from this study. But what we can see here is that there was they looked at various models here and effect size, and I don't follow all the statistics, but I think these graphs are fairly helpful. The idea is, do the lines go up or down at the point where this law was then applied in Scotland and England and Wales? And let me look at this again here. Scotland initiated this law, and England and Wales did not. So England and Wales are in the control group, and Scotland is in the experimental group. The design of this also implies that the driving capabilities of Scots and Englishmen and women are the same. Maybe they're not. Perhaps Scots are better drivers. I think they put more people in Formula One, but we can check on that. But at any rate, there's no difference. And so Reminds me a little bit about the law that might be passed in Germany about whether or not you can drive faster than 130 km on the Autobahn. Will this help? Since most of the accidents happen on country roads, nobody knows for certain. But laws don't necessarily result in the desired effect. The second paper in the Lancet involves calcium supplementation during pregnancy, which is generally done and probably a good idea. But we could randomize the women to it. This has been done 20 years ago, and the administration of calcium showed no effect. But these investigators weren't satisfied, so they decided to try this strategy again, looking at a whole host of primary and secondary outcomes that are listed here. But it didn't show anything. So it's a nice idea. It's well-meaning. Calcium carbonate doesn't cost anything, so probably give it. But don't be under the illusion that some magic is going to occur. The reviews in Lancet involve dengue fever. Notice this is an Aedes aegypti. Mosquitoes are flies, so they're insects. They have 6 legs, and when this organism bites, it has all 6 legs on the ground or on the skin. Anopheles mosquitoes generally have their hind feet up when they sting. Look at your mosquitoes so that you can tell the difference. Now, dengue involves large portions of the planet, and most people get away with, call this breakbone fever, because there's a lot of bone pain. But 20% get dengue shock, which involves vascular leakage and a whole host of problems, and it's impossible to predict who's going to get dengue shock and who's not. There's a vaccine for dengue. And we've looked at articles on this issue before, and where the results seem to indicate that although the vaccine provides protection, it doesn't protect against all strains, and there are 4 different strains of dengue. And the implication was that the people that are vaccinated, if they then get dengue, they actually do worse than the people that get dengue that were not vaccinated. And this is a major problem. It's also discussed here. So the second review is on osteoporosis. We would rather our matrix stayed like this instead of ending up like this, although the matrix that's made is calcified, so it's not like osteomalacia. And so bone remodeling, young adults, age-related bone mass, age has nothing for it, but it beats the alternative. So we look at anti-resorptive and anabolic strategies, and we can look at the fracture rate, which levels off once you get my age, but it stays bad the whole time. And we'd rather be in the lifestyle advice and reassurance group. But if you measure bone mineral density, even in the people that adhere to this, commonly end up in this. And so we can determine our treatment whether or not the people have osteopenia by looking at their T-scores and how many standard deviations they are from the mean. And we can do imaging. I don't think this one looks so great either, but it's normal. And people that can develop vertebral fractures, and whether or not these vertebral fractures are symptomatic is variable. They can be very painful, but a lot of vertebral fractures are asymptomatic. Then we can use fracture risk assessment tools, and there are calculators for this, and treatment options, and follow-up that should be done. And we've looked at the remarkable paper on solendronate in patients with osteopenia. It looks like a good idea. Then the question is, how long should these substances be given, these bisphosphonates? And oral bisphosphonates, according to the ideas today, should probably not be given for more than 5 years, because there are some problems with this. Intravenous bisphosphonates like solendronate should be given for 3 years, and then reassess the people and look at their fractures and bone mineral density, and high risk, low risk, consider what needs to be done and if additional treatments are necessary. That's it for the Lancet. This paper interested me because I happen to know the authors, so you're going to be subjected to it. It was in Science. It involves the baroreceptor reflex, which is what we use to regulate blood pressure minute to minute for our entire lives. And this involves a sensory arc inside great vessels, some magic that happens inside the brainstem, and then efferent pathways that have an influence on peripheral vascular resistance and heart rate. Now, even when I was in medical school, it was thought that this receptor mechanism has to involve some sort of attention proprioceptive mechanism to control this sort of thing. We didn't know about pressure-sensitive channels, but today we do. And these things can be studied with a technique called optogenetics, where we can introduce proteins inside channels so that they become light sensitive. And if we subject these channels then to green light or red light, they can fire, and we can look at their projections where the signals are going to. And optogenetics were used in this study. Now we now know that we have channels that in essence show a piezoelectric effect. You won't believe this, but the piezoelectric effects were discovered by Pierre Curie, married a famous lady called Marie, and his brother. And this was their first experiment. It involved crystals. And if you subject these crystals to pressure, it generates a current. And this is the piezoelectric effect. Are there channels that work in the same way? And there are, and they're called piezo 1 and piezo 2. These are two pressure-sensitive channels. And they've been worked up here at the Max Delbrück Center by Gary Lewin, who had this very nice paper on voltage gating of mechanosensitive piezo channels in Nature Communications in 2018. Now the story here by these authors at the University of Iowa looks at the role of piezo-mediated neuronal sensing of blood pressure in controlling the baroreceptor reflex. And they used optogenetics. So you can look at the different colors here and read this paper and you can figure it out. So they outfitted piezo 1 and piezo 2 with these proteins. This also involves Cree, so that this optic effect is then possible, and then you can study the baroreceptor reflex by infusing phenylephrine, that's the abbreviation PE, and then they looked at wild-type mice and mice with a knockout of piezo 1, knockout of piezo 2, and the double knockout to see if whether or not it obliterates the baroreceptor reflex. And here are the various colors, and you can look at the pictures in Science, and this, which I think is a great paper that shows how the baroreceptor reflex works and how the double knockout mice do. They don't do very well in regulating their blood pressure minute to minute. And this is the first direct evidence that piezo 1 and piezo 2 are the afferent sensors for the baroreceptor reflex. And that's the strategy, and I thought you ought to know something about it. Now we'll return to Earth, and we'll look at a bunch of young children in the United States with non-alcoholic fatty liver disease. And that this problem also already develops in children is remarkable. So the question here is, if we get these children away from eating a bunch of sugar, could this condition get better? Is this a function of eating sugar, or is this a function of weight loss? And so this variable was looked at, and what we see here is the low sugar diet. These kiddies' MRIs of their livers got better. Everything that goes down here is better, whereas with usual diet, this is a scale from lowest to highest degree of fatty liver involvement, and the kids on the usual diet just fluctuate around this line, whereas the kids on the low sugar diet get better. And their liver enzymes get better, whereas with the usual diet that doesn't, and their SGOT levels get better. And so there's no doubt about it, it's the sugar, and if we can get these fat kids from taking all this simple sugar, their fatty livers might get better. So we'll finish with this. This poor 85-year-old woman comes into the medical department, and she's suffering from weight loss, and nobody knows exactly why, and she hurts all over. The technical term for this is malaise, so she hurts all over. She has a little Alzheimer's dementia, so communications are a little different. Her erythrocyte sedimentation rate, yes, that's still being measured, was elevated. It wasn't 100, it ought to be 10. Instead, it was 50. And so the doctors didn't know what was wrong with her, so they measured CRP, and that was also elevated. And then they looked at this and that and the other, and finally they did some high-tech imaging. And the high-tech imaging led them to do a biopsy of her temporal artery, which I wish I could see, but that wasn't shown here. Instead, what they showed us is this PET-CT, which shows inflammation of these large vessels. And this is an example of giant cell arteritis, where the temporal artery is almost always involved. You can palpate it and you can biopsy it. We never needed PET-CT to make this diagnosis, but I guess medicine's changed. That's it for this week. Join me for next week, and if you'd like to hear the same business in 4 minutes in German, stick around.